Every day, a large number of people, both children and adults, experience medical intervention and care at Triple M. They walk in through the doors of Triple M as patients and walk out with a new lease on life. The Madras Medical Mission Hospital, since 1987, has been synonymous with excellence in patient care and quality medical treatment at an affordable cost. And it continues to draw a large number of patients from various stratas of the society. The Institute of Cardiovascular Diseases, ICVD, at Triple M has many firsts to its credit, including the first adult and pediatric heart transplantation in the private sector, percutaneous pulmonary valve implantation, first bilateral lung transplantation, first Ross procedures, first Batista procedure, and so on. The Institute is made up of several departments, including departments for adult and pediatric cardiology and surgery, and a department for cardiac rehabilitation. It is also home to some of the finest cardiac specialists in India. The catheterization lab at the Cardiovascular Diseases Department is a state-of-the-art facility that brings in a multidisciplinary team of doctors. It is here that diagnostic angiographic procedures and therapeutic interventional procedures are performed. With every surgery performed, with every patient treated, the Cardiovascular Diseases Department at Triple M reinforces its commitment to its missionary values. Every patient that comes in for treatment at the department, from a day-old baby to a 90-year-old, is an opportunity to further the Madras Medical Mission's goal of reaching out to the unreached.
Good morning, sir. In the panel we have Dr. K. Subramanian, sir, Dr. Elilan, myself, Dr. Nilambajan, Dr. Arun Kumar, and few other cardiologists. Good morning from Poor, sir.
Extremely nice to start your wonderful meeting in Puar with a transmission from Madras Medical Mission. And I heard that in the last 2 hours you had a wonderful teaching session for the postgraduate students by Dr. Sivakumar, Dr. Vijay Raghavan, and I hope you are having a wonderful, nice time there. We will give a brief presentation of the patient. Dr. Shan, who is my colleague, will be describing the patient.
Good morning. Thank you very much.
Dr. Shan?
Thank you, sir. I'll be taking you through the case now. 63-year-old gentleman diagnosed to have chronic MR with severe pulmonary hypertension underwent a mitral valve replacement in September 2016 using a 29mm Perimount valve. 3 months following his surgery, he developed progressive breathlessness and currently in class 2 to 3. His current medications include clopidogrel, bosentan, ditor, alducton, and ramipril. On examination, he had a weight of 79 kilos, pulse rate of 70, which was regular, a blood pressure of 130/70 with a JVP elevated 2 centimeters above the clavicle, cardiomegaly, loud P2, 3/6 pansystolic murmur at the apex. On a chest X-ray, showed cardiomegaly with a cardiothoracic ratio of 65, prominent PA segment with right atrial enlargement with mitral valve bioprosthetic valve that was seen. On an ECG, showed a sinus rhythm, a ventricular rate of 75 per minute, left atrial enlargement, left axis deviation with prominent LV forces. To the transthoracic echo in apical 4-chamber view showed a dilated LA-LV, good ventricular function, moderate TR with a peak gradient of 89 with a calculated RVSP of 99. A 2D transesophageal echo showed a well-functioning mitral bioprosthesis valve with an inflow gradient of 15/6 with a large anteromedial paravalvular leak. A 3D volume rendered image showing the mitral bioprosthetic valve with a crescentric anteriorly placed paravalvular leak at the outer mitral curtain. The same 3D image showing the paravalvular leak measuring 17/10. A zoomed-in view of the same image focusing on the mitral valve and paravalvular leak, and a similar view showing a color flow through the mitral valve bioprosthesis and paravalvular leak. So the plan for today will be a device closure of mitral paravalvular leak. Thank you.
Subramaniam, Dr. Nilambajan, I think you have heard the story so far.
Yes, sir.
Dr. Srija, who is my colleague, is going to show the echo images live right now. Srija, can you show the live echo images?
Yeah.
Go to echo big.
Good afternoon. These are the TE images recorded in the cath lab. So it's a 4-chamber view which shows left atrial and left ventricular dilatation and normally functioning mitral bioprosthesis.
The moment this is over, I want echo navigation screen.
Here you are seeing the anterior leak, large paravalvular leak in relation to the left atrial appendage, and color flow shows significant quantum of paravalvular regurgitation. This is the explain of the image, explain imaging, which shows the leak, and the leak was measuring maximum of 15 millimeter.
Echo navigation will come.
This is a 3D zoomed image of the same, showing viewed from the left atrial side, which shows the anterior leak here, and the mitral bioprosthesis. And this were the measurements maximum. It's an oval leak measuring around 15 into 8 millimeter.
Just show the previous picture. Thanks, Dr. Srija, for the nice illustration. Show the echo again. Continue showing the echo. Yeah, you can appreciate that the aorta is in the 12. Show the echo.
What it?
Yeah, the 5th frame. 5th. Yeah, you can appreciate that the aorta is at the 12 o'clock to 1 o'clock position on the top, the broad, big, round shadow. The bioprosthesis, which is the perimount valve, is seen, and this is on the aortomitral curtain. The aortomitral curtain is one of the weak areas, and we call the left fibrous trigone and the right fibrous trigone on the edges of the aortomitral curtain. And this leak is on the left fibrous trigone of the heart. If you heard the story before, this patient was having an extensive mitral annular calcification when the surgeon went in for the mitral valve replacement, and this was done through the minimally invasive technique through a right anterolateral thoracotomy. It's possible that the calcifications were preventing the surgeon from getting very strong anchoring sutures. I also have a worry about whether the minimally invasive technique will not expose the mitral valve extremely well, and whether that could have been a contributing factor. The hemodynamics when we did today, the pulmonary artery pressures were very, very high. The pulmonary artery pressure, can you show the PA pressures there on the hemodynamic monitor? So the pulmonary artery pressures were 105 millimeters of mercury systolic. You can't show that? Okay, so it was 105 by 40 with a mean of 63 millimeters of mercury. There was very severe pulmonary hypertension. Right now the technology that we are going to use will be echo navigation. So by echo navigation, what we mean is we are going to plot on echocardiography the markers that are going to enable us. You can appreciate here the marker that we have placed on the intratrial septum as guided by the echocardiography, the paravalvar leak here and the left atrial appendage, and we are going to go with the septal puncture now. The septal puncture is done in the usual traditional manner. Srija, get it on. Yeah, why plane? So right now what we are doing is we are coming down on the septal puncture needle, and as soon as we reach just cross the limbus of fossa vallis, so right now confirm the position on the echocardiography, show the
stenting, sir,
echo screen. Now make it 4. So you can appreciate that our needle is indenting on this intratrial septum. So right now what we are doing is come to RAO. So we are going by the routine fluoroscopic markers where the needle tip is anterior to the descending thoracic aorta. Come to LAO. So we are now here trying to indent the septum. I am going on the 4 acquisition. We are Srija, I want to see the indentation of the atrial septum. Yeah, there it is getting indented. And now
Aqua.
I have advanced the needle.
Aqua.
It's staining some portions of the atrial septum, you can see. So I am taking back the needle. Yeah, right now I am in the left atrium.
Yeah.
Sivakumar, this is Kannan.
Can you see the contrast in the LA, Srija?
No.
Actually, it is, you can see that there is a duplication. Yeah, Kannan. There is the slight duplication of the intraatrial septum. Kannan, I am hearing you.
Yes, please go ahead. No, just for the audience, we had seen a very large paravalvular leak. And
Kannan, you can appreciate.
yeah, Dr. Sivakumar is going to close it with a device.
Yeah.
And the usual approach is to do the intraatrial septal puncture, go to the left atrium, cross the mitral valve, and deliver the device from the left atrium.
Yeah, not entered.
Now,
Srija, I
what
want to
he's
see the
trying to show is
indentation.
to do the
you're
intraatrial
showing that.
septal
That's the
puncture
indentation. You're
with
indenting the septum. You have
not just with the
gone
fluoro
into
guidance, but also by the echo guidance. Sivakumar, my question is the puncture here what we are trying to do, is it anyway different from the usual puncture what we do for balloon mitral valvotomy? It should be higher, lower, something like that is there?
It is, yeah, this preferably this needs to be, this needs to be posterior and superior, so that we are away from the mitral valve as much as possible.
Right. So generally, when we
Go to
want,
lateral view.
yeah, when we want to cross the mitral valve during our routine balloon mitral valvotomy, we will be puncturing the central portion of the IAS, say fossa ovalis portion, that will direct us to the mitral valve. But here,
Central portion or more and more inferiorly, basically.
more, okay. Now here it is, we have to reach the annulus portion of the mitral valve. It's not the central portion of the mitral valve. So it should be more posterior and more inferior puncture, isn't it?
Yeah. No, more. Actually, this needs to be posterior and show the this one bigger, the fluoroscopy bigger.
It's hand, maybe cable. Yeah. Echo. Is it echo hand? Some
So
hand we are seeing. Is it some echo hole?
The wire has gone through. Now I'll make the. No, not the. You just
Echo navigation is
hold it.
being done. Is it echo probe holding? Yeah, that's right. Yeah. Right.
So we are trying to get the puncture into the intraatrial septum. This patient had if you carefully look at the long axis view of the echocardiography, something like a duplication of the septum. Srija, are you able to see an indentation? Okay. We are staining the septum again.
Yes. Can we see the location of the septal puncture needle in the AP view, just to tell us exactly, to get the same understanding? We have seen in the lateral view. Just once,
Yeah.
can we see in the AP
Yeah.
view?
Come to AP view. Yeah. Come to AP view. Yeah. So can you get the needle tip now, Srijan?
Where is the pigtail ending? Yeah, pigtail is here.
If you
Okay.
see now you are going actually pretty,
Quite high. Quite high. Puncture
pigtail is in the aortic root. It's
yes.
sitting in
So the needle
quite
is
high.
quite high.
the posterior, it has to be in the postero-superior aspect.
Right.
So that, no, that is for the regular mitral valvotomy or regular entry, but here we want to be away from the mitral annulus.
Okay.
So that we want to go high and dive into the mitral valve. No, I have not yet punctured so far. You have to show the indentation. Yeah. And put a explain on that area. Yes. Okay. So right now in this area, since there is a duplication of the atrial septum, Kannan, are you able to see
Yes,
the
yes, yes.
atrial
Yes,
septum
yes.
being indented?
Exactly. Yeah, we are able to see the indentation very well.
What's happening is in that place, slightly rotate Srija. Yeah, but there is a duplication of the atrial septum. Can you see that on the longitudinal plane?
Yes. And it seems you have crossed, isn't it? Echo-wise, it seems the needle has crossed.
No, I am not, actually I am entering into the duplicated, that sac-like area.
Area, okay.
No, actually that is not the needle. What you are seeing there is the duplication of the septum.
Okay.
The septum is doubled up in the superior portion.
Right.
I will just make that picture bigger. You can appreciate here in this area that the septum has actually duplicated.
Okay, okay. No, that we wrong.
So what we are entering,
yes.
see this is the superior vena cava.
Exactly.
And this is the atrial septum. The atrial septum, yeah, this is the atrial septum which is getting duplicated there. See now when I am entering, I am going into that sac. Give me some contrast, sister.
Yes. We did
Contrast.
see something projecting there, yes.
Slightly take out the T probe, Srija. T probe slightly out.
Yeah, live fluoro when you give the contrast.
Yeah, so the small screen that you are seeing on the corner is the atrial, like the real live fluoroscopy. See, it's entering into that crevice and it is coming back. So now what I will do is I will try to go a little lower than that area because, yeah, Srija, can you show me the place of my indentation?
Sivakumar, just one
Yes,
question. What do we
just
see
stay there.
LV
You can now
apex
appreciate
somewhere
on the
at the tip?
echocardiography the duplication there.
Yes.
Yeah, there is an apical sheath also.
Oh, you already put the apical sheath. Okay.
There is an apical sheath. I'll just describe it once again. Yes. Stretching the septum, but can you slightly take it out, the probe? No, not so much.
Dr. Sivakumar, the question asked from the floor is, if we have already got the
Show me the
apical
place of my
catheter,
indentation.
is there an advantage to try still from the left atrial side? Why can't we directly go from the apical side and finish?
Yeah, now we have. Actually, this is a very, very large paravalvular leak. Then I have to put in a huge apical sheath.
Okay.
This is now what we have got is a very small apical sheath. Srija, can you show me where we are? T probe out, slightly out. T probe slightly out, little bit out. Srija, I want to see the fluoroscopy. You can take out little bit more. It's hitting the roof there.
It seems it's repeatedly going there only. Will giving a slightly additional bend
Yes.
to the tip of the puncture needle help?
Get it. I'm thinking about it. Yeah, just I'm slightly going inferior now.
Yes.
And can you reintroduce the probe station? Now show me the place of my indentation. Yes. Yeah, you unable to explain here? Show me now. I'm again going down. Little bit push the probe inside. Yeah, I'm indenting the septum. It's entering into that crevice area. Sister, now can you get me 014 thermo wire? See, what we are seeing is the contrast is entering the LA. You can appreciate on echocardiography.
Yes, it's below the left. Yeah, now.
No, it's not entering. Sorry.
We saw something in pulmonary artery or something.
Yeah. It
was pulmonary artery.
Yeah. Actually, it was probably entering into the right area. So now I have taken out the needle. Show the indentation again, Srija. Same space. Okay. In fact, I made a little bit more angulation on the needle, but now I'm making it further more. Get me the thermo wire. Thermo. So right now we are again entering into the superior vena cava. Advancing the transeptal sheath. Now reintroducing the needle. Made much more of a bend right now. Show the place of indentation, Srija. Come to RMO. Yeah, come to LMO, come to lateral. Table up.
Yeah, show the diaphragm, please. Yeah. Move the table so that we see the diaphragm.
Slightly come up.
Yes, this is fine.
Okay, now give me the thermo wire. See, I am in the LA because I have started getting the contrast within the left atrium. So right now, in order to ensure that my needle doesn't poke, I am advancing the 1/4 coronary wire through the transeptal needle and allow it to coil it into the left atrium fully. Now this wire is not. I'm not getting a free flow of left atrial blood back into the left atrium. You are able to see the contrast in the echocardiography. You show that, don't show my face, show the echocardiogram there. Yeah. You can appreciate the contrast that I am injecting into the left atrium.
Right.
Not air, contrast. Keep it running. Echo, let it be running. I'm trying to get a coronary wire across. It's getting stuck at the tip, which means sometimes we are not in the desired location at all. I want to see a better picture, Echo.
Shiva, I happen to be sitting here. Try a CTO wire, Fielder FC or hydrophilic CTO wire will get through.
Yeah. Now we have gone into the left atrium. You can see the contrast on the left atrium, and now I am advancing my sheath inside. So the sheath has gone. Come to AP view. So can you identify the sheath now? Right now I am going to make so this is the left atrium. Right now we will take a pressure on the left atrium. Sister, give heparin 5,000 units. 5,000 units heparin right now. Show the LA pressure big, pressure line bigger. So we have a pressure of close to 40, 42, like V waves going to 42 or so, and the mean pressure of close to 20 millimeters of mercury.
Right.
So right now what we are going to do is advance the coronary gate catheter with a snare. We'll just show the snaring, and we will the other lab. Actually, the other lab is also ready. So what we will do is we'll just show the snaring part, and then come advance it. Snare. Yeah. Open the snare.
From where? What you are going to snare, Sivakumar?
Open the snare and keep it there. Basically, there is an apical sheath you saw.
Yes.
So that's a transapical sheath which has already been there.
Right.
So right now what we are going to do is we are going to advance
Wire from the apical
right coronary catheter from the apical sheath and snare that into the
left atrium.
straight thermo wire. Correct. Because this is a leak that is located on the aortomitral curtain area. If you are taking a arteriovenous loop, this is going to be difficult in slightly withdrawing it. Hold the tip. You can see that we are going through the paravalvar leak.
Yes, into the pulmonary wing.
We are out of the valve.
Yes.
And now so right now I am inside the LA. Now I am taking out the, Srija, confirm that we are through. Yeah, you can show the echo picture also bigger. Get the J wire. Come, introduce the J wire into this.
From the apical root. Yeah, we are able to see the wire clearly through the paravalvar.
Yes, so now right now we need to make the whole assembly come through our snare. So I'm going to take the wire. This is what wire is this? Not J Termo, J Teflon wire. So this is a J Teflon wire that is going out. It's going into the appendage region? Yeah, so now I am torquing it.
Okay. Seems to be through the snare now.
So we are torquing this right coronary artery catheter towards the left side of the atria. So then catching the wire.
Now, yes, very good.
Once the wire is caught, we try. We are trying to go to the tip of the guide wire so that hold the catheter here.
Now you can advance the sheath
Wire leave it
to the LV.
So right now we have created an epico-venous circuit. So now what I will do is, see right now, Kannan, the other lab is also ready.
Right.
So Dr. Matthew will show right now the next step will be to put the device across.
Yes.
So we will just break briefly.
Yes.
Because through the apical sheath, now this whole epico-venous circuit, now we are going to advance the guide wire.
Yeah.
So Dr. Matthew will take over from right now in the other lab, and I will come back to you.
Thank you, Sivakumar. Can we go to the next lab, please?
Not the same sheath. We are going to put in a larger sheath.
Okay.
Thank you.
We are back with you. We have just 2 minutes.
RC catheter.
Can you tell us?
Yeah.
what we have
Can you
done
just
so
show the last two fluoros? Can you show last two fluoros? Yeah, I'll let you know. See the previous. Yeah, you see this is the device that we are taking up. The actual echocardiographic measurement was around 16 millimeter by 16 millimeter by 10 millimeter. So we took. Can you show that? Yeah. So what we were doing was, this was a 16 into 10 Occlutech Paravalvar device which has got 3 millimeters waist on all the other sides. So then show the next picture. You can also appreciate that the apical wire was still across the paravalvar leak. So that in case if we want to recross, then we can recross. But what was happening was this device was popping through. You can appreciate now in this view that it had popped through, and now we are trying to get our. You can see now I am going live. I am now crossing the paravalvar leak because our sheath is just at the mouth of the paravalvar leak. So this has gone into the left ventricle. Give me the stiff wire. Give me the stiff wire followed by the dilator. This was a large paravalvar leak which was causing a high LA pressure, high pulmonary artery pressure. So what was happening was that 16 into 10 Occlutech paravalvar leak device, which is a rectangular device, was coming out very quickly. So right now I am advancing the stiff wire through, and with the stiff wire I am advancing the sheath through. So the sheath is now across the left ventricle. So we are getting the pressures from the left ventricle. So right now I am taking the device. You can see the device now. This is a rectangular device. Show the camera. Show the camera.
Yeah, we are seeing. Can you
Focus on the camera.
Yeah,
Zoom it.
close up.
Yeah. Zoom further. Zoom further.
Yes, now we can see.
Zoom further. You can see that it is a rectangle. Yeah, stop. So this is a rectangular shaped device. Now this has got 2 discs. So the dimensions are, you show the paper now.
The dimension what you mentioned 16 is the dimension of the waist.
Flush it. No, actually this is now I am taking, because the 16 came out, now I am taking the larger device. It's 18 into 10 now.
Now what
18 is the waist on the long axis, and 10 is the 18 is the long axis of the device, and that's all in the waist. The device will be 3 millimeter larger on either sides. So right now the device is coming up.
Can you have the echo also, please? Or is somebody doing echo? Can you see the echo also?
Yeah.
Instead of the hemodynamic parameter.
Yeah, Srija is doing an echo. Show echo parallel. Enable this mouse. No. I want. See, it's actually coming out. It's popping out very easily into the left atrium. So yeah, it's a big leak. But what I feel is sometimes this may be created by the guide wire that I have kept, which is allowing it to pop out. So next I'm going to try out without the guide wire. So right now I'm going to pull out this guide wire out, so that there is no impediment on my device when it is coming out. Get that same RCA catheter. RCA catheter. Yeah, put the straight thermo wire. So we are advancing the guide wire. It will be nice if I have the yeah, it is gone into the LV. So now what I am doing is I am advancing the catheter into the LV. Now I want the stiff wire. Dr. Ailen, are you still with us?
Yeah. We are with you.
Yeah, we are watching.
Hello?
Yeah, we are watching, Sivakumar.
Okay. Okay.
Yeah, we can see the guide just now crossing the lead,
so right now,
the LV.
Okay, fine. So right now what I am doing is, yes.
You have taken back the JR, or taking back the JR. Yeah, now only the sheath is there. We're going to try the same device.
So right now I want now the device again. Yeah. Actually this is the largest device, Kannan. So beyond this there are no devices that has been made. So my assumption is that it was possibly the guide wire was preventing it from conforming.
Yes, it might be preventing it from taking the shape. So that's why it's Sivakumar, there is a request that we should go to the next
Yes,
program.
so right now I am going to,
So you can finish and show us the final version after some 20
yeah.
minutes or so.
So I'm just taking the device inside.
Yes.
Maybe we'll see till the device deployment and then
Okay,
we'll
you are-
break off and we'll get back to
So
you
right
when
now the
you're
device is,
Yeah, we can see the device coming out.
yeah, but it is, okay. So Srija, how is the position? Show the echo big, 3D bigger, echo 3D bigger. Yeah, 3D, Srija, go on 3D zoom that in that area. Yeah, make it bigger. Yeah. Now, not the ventricular side, turn it and show the atrial side. Reduce the smoothing on the, reduce the smoothing. Yeah. Now, rotate it, the LA appendage should come to 10 o'clock. LA appendage to 10 o'clock, Z plane rotate. Z plane rotation. Yeah. Now, actually the hemodynamics also is becoming better. The LA pressure has come down significantly. Show the LA pressure bigger. Srija, as you are concentrating on the device, just check. Show
we are
the
watching
show
the
the
peak
hemodynamics
is-
bigger.
Yeah. The one coming in white is LA, isn't it?
See, actually the LA pressure has come down significantly. It's just, yeah, white is LA. It's just 10 now. You can appreciate the previously the LA V waves were crossing
40, it
42,
was around
43.
40.
So now right now it is around 10, yeah, 11 to 12 now. You can appreciate there is a significant reduction. Yeah, right now again go back to again go back to the echocardiogram bigger. Yeah, focus on the picture. Smoothening reduce. Yeah, let it be harsh. It's okay. So now the device position is looking fine. However, there is some degree of residual flows, which I think will be there for some time because we have given full dose of heparin. Srija, can you go on to 2D now and cut it? Just confirm that the device is perfectly secure on both the discs on either side. Yeah, go ahead. Kannan, Dr. Matthew is just showing his last picture there on the other lab.
Yes. Yeah, we'll see that and we'll have a couple of presentations here and come back to you.
Basically,
for the
here
final.
we are just
Dr. Sivakumar,
Yeah.
it was a very beautiful demonstration of echo navigation.
okay.
and
I don't know whether
closure
the
of
transmission is open.
Paravalvular leak. Let us give a big hand to Dr. Sivakumar.
Yeah, we can go to Dr.